Hello, everyone. So, today we're going to be talking about diabetes. This is a very common chronic disorder that has affected literally about 11.3% of the US population and very similar percentage also in the entire world. In fact, it is proposed that by 2045, we're going to have almost 1 in 8 adults affected by this. So, yes, it is a very important disorder for us to look at. So, we are going to be talking about the pathophysiology of diabetes. We'll look at how that happens. We'll define the disease process. We'll look at the types of diabetes that we have, the symptoms of it. We look at how it is diagnosed, how it is managed, and what are some complications that these patients might have. So, first of all, to understand diabetes, we have to understand the organ that we're dealing with. The pancreas is our main organ here. It's a dual gland, meaning that it does two things. It helps you with your exocrine functions. So what's your exocrine function? So when you eat food and your food gets into the small intestine, the pancreas is one of those organs that assist in the metabolism and absorption of your food. So it will release amylase, lipase, or protease. So those help in breaking down your food. But that's not what we're focusing on here. We're focusing on the endocrine function of it, which is what it does 5% of the time. And this happens mostly in the islet of Langerhans, which is the part of the pancreas that secretes those endocrine hormones that we're going to be looking at. So your islet of Langerhans secretes four hormones actually. We have it has alpha cells which secrete your glucagon. We have your beta cell which secretes your insulin and your amylin. That's what we're focusing on today. And it also has delta cells that secretes gastrin, somatostatin, and then the F cell which secretes your pancreatic and polypeptide hormone. But like I said, we're focusing on the beta cell, or rather the insulin part of it, um, secreted in the islet of Langerhans, which is the endocrine aspect of the pancreatic function. So, talking about insulin, you've got insulin. We also mentioned just earlier about the beta cells, the alpha cells secreting glucagon. So, what's the difference between those two? Actually, they do opposite of what the other does. So, your insulin is the very common one. It decreases your blood sugar and your glucose. All right, so we'll be using that word interchangeably. Your glucose, sugar, we're still talking about the same thing, okay? So insulin decreases your blood sugar when you eat food. Glucagon, on the other hand, increases your blood sugar. Why would I ever need my blood sugar increase? Because sometimes you might have exercised a whole lot, or you haven't eaten for a really long time, you're fasting, your blood sugar might drop a bit. So glucagon is what comes in to help with that. So we do need glucagon, which is also once again secreted by the alpha cells in the islet of Langerhans in the pancreas. All right. But once again, we're focusing on that insulin part of it. So let's look at insulin a bit deeper. How does insulin help me when I eat, and how does it decrease my blood glucose? So when you eat a food, with the carbs, protein, fat, combination of all of that, when you eat that food, it goes through your digestive system and your blood sugar increases. All right, the exocrine part of the pancreas does its part, but the endocrine part also kicks in because now your body recognizes, oh, blood sugar has gone up. All right, um, which is kind of like a state of hypoglycemia, which is the terminology for that. Hypoglycemia means increased blood sugar. But someone who has a good functioning pancreas, the pancreas is working as it should, it triggers the beta cell of the pancreas, which you just mentioned, to secrete insulin. So what insulin then does is it opens up. Insulin is literally like the key that allows all that glucose that is in your blood to be taken into your cell so it can actually do what it needs to do. All right. When you eat food, you're eating food so that you can get energy from it. You're eating food so it can do something for you, right? But your body really cannot use that glucose until insulin comes in. All that glucose will just be in your blood, increasing the sugar level in the blood, which we don't need. We need it to go from the blood into the cells, into your fat cells, and do what it's supposed to do. So insulin being released from the beta cells of the pancreas allows that to happen. And some of it are used for energy. Some of those glucose is used for energy. But sometimes you eat too much food and your body does not necessarily need all that glucose for energy, at least right now. In fact, sometimes when you eat food, you're not even doing much. You probably finish eating, or even while you were eating, you were watching TV. So you're not really using the energy as much, right? You're not using as much brain power, you're not working out. So your body most likely would use what it needs, takes the little it needs for energy, and it will store the rest of it. There are two common places that this excess glucose is stored. It's stored in your liver or in your muscles. And it's not stored as glucose, it's stored as glycogen. All right. So next time maybe you haven't eaten for a really long time, what your body would then do is glucagon this time around will be the one that is secreted. Remember glucagon, our friend? That's the one who increases blood sugar. So glucagon this time will be secreted and it allows your liver or your muscle to convert that glycogen back into glucose so your body can use it for energy. So now that your body has absorbed that glucose because insulin has been released to decrease the sugar in the blood, your blood sugar will then go back to normal, which is what we call euglycemia. That's just another and it's a fancy medical terminology for that. All right. So now that we actually understand how insulin works in someone who doesn't have diabetes, let's talk about diabetes. Let's give it a definition first. So diabetes is pretty much a chronic multi-system disorder. Yes, your pancreas is the main organ at fault here, but by the time diabetes starts to manifest itself, it's not just going to affect the pancreas. It's a very systemic issue because we're talking about the blood sugar here. All right, blood is flowing throughout your entire body. So if there's a lot of sugar in your blood, you can imagine how that can be affecting the entire body system. So it's a disorder of impaired carbohydrate, protein, lipids, pretty much your whole food. It impairs their metabolism, the way they're used, because one, it's either you're not producing enough insulin because that's what it's supposed to do. It's supposed to help you decrease your blood sugar. Is it that you're not producing enough of it or you're not producing at all? Or you are producing, but your body is not able to use it as it should. Or it could be a combination of both. We'll have more understanding to that as we go on. What should your normal ideal blood sugar be? If someone doesn't have diabetes, it should be about 70 to 100 milligram per DL. The reason for that is because your body always tries to keep your body in what we call homeostasis, so that stable equilibrium, that good place. So actually, your pancreas releases insulin throughout the day, but in small amounts and just little bits and pieces, just to keep it within this range. Um, but the moment you eat something, it's then gonna push out a whole lot of it because now we really gotta work on that food. Back to the process we talked about earlier. One look at the different types of diabetes that we have. The first one is type 1 diabetes. All right, we do have so many different types, but we're going to be focusing on just two, type 1 versus type 2. The problem with type 1 diabetes is that beta cell. Remember, the insulin is secreted from your beta cells of the islet of Langerhans in the pancreas. So those beta cells are being destroyed. So it's either they're not producing enough insulin, or in most cases, they're not producing any insulin at all. But in type 2, this person does have insulin being produced. Right? The problem here is resistance. All right, they are producing insulin, but the problem is the body cannot use it as it should. So when it gets into the receptor cells that are supposed to accept the insulin and allow it to work, it's kind of like you putting a key into a padlock and you turn it and it opens up the lock, but that's the problem here. We have the key, which is the insulin. We put it, but the lock is not opening up. It's not opening up our channel so that glucose can be absorbed into the body. So there's a resistance. It's not being used as it should. So that's the problem oftentimes with type 2 diabetes. So for easy understanding is put them side by side and do a quick comparison. You should know that type 1 diabetes used to be referred to as juvenile onset diabetes, But we do no longer use that name because now even adults are having type 1. And type 2 used to be the one referred to as adult onset. But again, now we have younger kids acquiring type 2 diabetes. Type 1 also used to be called insulin dependent because these people are literally dependent on insulin. They need insulin. While type 2 used to be called non insulin dependent. But again, we don't really do that anymore because while your type 1 is still very dependent on insulin, there are some type 2 patients that might need insulin too. So that is not a good definition or a good name. So we just say type 1 versus type 2. All right, so type 1, remember the problem here is that the beta cells are being destroyed, so they're not producing insulin at all, or maybe they're producing it just very little. But your type 2, like I said, we're not able to use insulin as we should because there is a resistance by the target cells. What causes type 1 is usually autoimmune. When we say something is autoimmune in nature, it means that your body is most likely fighting against itself. It doesn't recognize. Most likely, that is usually triggered by a virus that this person has probably had previously. It could also be genetics, a little amount of it. Type 2 can also be genetic to an extent, but most often time it is often due to this patient being overweight, obese, or due to just physical inactivity in general. So type 1 is the very low percentage. About 5 to 10% of people who have diabetes have the type 1, but most people who have diabetes, they most likely have the type 2. So this accounts for about 90 to 95% of our diabetes mellitus cases. The very common manifestation between both of them is that ash blood sugar is going to be through the roof. All right, so hypoglycemia, that's the terminology for that, increased blood sugar. Body weight. Most of your patients who have type 1 diabetes, they're actually normal in weight. Some of them might be overweight, a little percentage, but most of your type 2 diabetes patients, 80% of them are overweight and might actually be obese. What are some symptoms you will see with your type 1? Now, because type 1, the problem is that the beta cells are being destroyed, the symptoms are very fast. All right, it's sudden, it's very acute in nature. So we have the polyphagia, polydipsia, polyuria. Polyphagia is excessive eating, polydipsia excessive thirst, polyuria excessive urination. I'll talk about this a little bit more on our next slide. These patients also get very weak and they might also have a lot of sugar in their urine because the body now has so much sugar in the blood. And remember, blood always passes through the kidney, gets filtered before it returns back to the heart. So when the blood passes through the kidney is gonna go, oops, that's a lot of sugar. Let me try to filter some of this out. All right. So you end up having a lot of sugar in your blood. Usually we shouldn't have sugar in our urine. But now that we have excessive sugar, we might be finding sugar in the urine. The reverse is the case for type 2. It's not as acute or sudden like your type 1, it's more gradual. So this patient might even be asymptomatic for a while. They might not even know that they're diabetic. So a lot of people are actually walking about diabetic, but they don't know yet. But by the time the symptoms starts to manifest, they're going to have very similar symptoms as your type 1. So treatment, we're going to focus on that a bit more later too, but insulin definitely for your type 1 because again, remember, they're not even producing at all. Their beta cells are being destroyed. So they definitely need a take form of insulin. When somebody doesn't have something, and that's the problem, we got to give it to them externally. So that's our insulin. Diet also can help them. Their exercise also can be very helpful. For your type 2 patients, some of them take insulin, but it's not their main go-to unless they necessarily need it. But their diet, oh yes. Remember, the problem is here is some of them acquire type 2 in the first place because they were overweight and obese. So they do need to watch their diet now. They need to try to lose some weight. They need to exercise. And we have another class of medication called oral hypoglycemics. They're not insulins, but they do help to enable this type 2 patient's insulin to work. You remember we said the problem is that the key wasn't unlocking that lock. All right. But with this oral hypoglycemics, it allows the insulin they're producing, which is the key, to hopefully now do its job and unlock without resistance. All right, it's kind of like you're putting oil. It's like you have a lock that is very rusty, and you're trying to use a key to open it, and it's just not working. And you apply some oil to it to loosen it a little bit so that it can finally open up. Right. So similar situation. That's what your oral hypoglycemics kind of do. To put it in a simpler term. All right. So we're gonna look at those symptoms a little bit more. When you think about diabetes, I want you to think about the three P's. The three P's. We have the polyuria, polyphagia, polydipsia. Polyuria is excessive urination. Why is this person urinating a lot? There's a lot of sugar in their blood. And the kidney is gonna go, let me try to get this out. All right, and they're also urinating a lot because they're drinking a lot of water. All right, the polydipsia. You drink a lot because your body is like, hey. You have a lot of sugar in your body. Let's dilute it. Let's try to dilute the sugar in the blood. So that causes you to get thirsty and you want to drink. And not because you drink, you gotta pee. All right. So that's polyuria and polydipsia. Polyphagia also because even though you're eating, remember insulin is what allows what you've eaten to be used by your body for energy because it's the key that opens the door for your glucose to be used as energy. But now that your insulin is not working, all the glucose is in the blood. They are not able to enter into your cell. Your body's going to be telling you, hey, I'm still hungry. You haven't eaten. I know you think you've eaten, but we can't use what you've eaten. All right. So that's why the person keeps getting hungry and they they want to eat more. Other symptoms that you might see, which again, these three P's are very common to both type 1 and type 2. The only difference is you will see it faster in type 1, but type 2, it occurs much later. What type 1, they might start to lose some weight, they're weak, they're tired. There's a lot of ketones in their body. Why? Because their body starts to use ketone for energy instead of fat. All right, it starts to use ketone for energy instead of fat. So they go into ketosis, and now there's a lot of ketones in their urine, in their body, and if it gets really bad, it might even go into a metabolic acidosis state. For your type 2, they also get a bit of fatigue. They get a lot of infections. Their wounds don't heal easily, so if they get injured because of all that sugar in the blood, the healing process is very slow. They start to have some visual changes as time goes on too. All right. A question that you need to ask is, or you might be asking is, will my type 2 diabetic patient ever need insulin? Now, we mentioned that the problem is that type 1, they are the ones whose beta cells have been destroyed. So they surely need insulin, right? But your type 2, they still have their beta cells. It's still producing insulin. It's just not working well. So will they need insulin? Yes. The answer is yes. They might need insulin at some time. And when would they need that? As the process progresses and worsens. With time, the diet, the exercise, the oral hypoglycemics might not cut it anymore if this patient is not managing the disease process very well. So they might need insulin with time. Also, whenever this patient is stressed or they're sick or they're going for surgery, they will most likely need insulin during those periods because stress, illnesses, surgery, because most likely when people are going for surgery, they're anxious. Their body is about to go through some stress, some form of stress. These are things that will secrete epinephrines and your cortisol and all of that. And these don't help your blood sugar, they make it even worse. So in those situations, they might need insulin. And then of course, pregnancy. The reason for that is because if this patient was a type 2 diabetic patient, or if they have another type of diabetic that we're not going to talk about, is called gestational diabetes, which is where the mom develops diabetes because of pregnancy. She would have to take insulin, not the oral hypoglycemics, because those are very harmful to the baby. We say they are teratogenic. All right. That means that they are harmful to the fetus. The next concept we're looking at is now how diabetes is diagnosed. How do we diagnose diabetes? There are a couple ways that diabetes can be diagnosed, but the first one we're going to look at is the A1C. What's the A1C? It's known as the hemoglobin A1C. All right, so it's commonly written as just A1C, or it might be written as HbA1c. What it does is it measures the percentage of glucose that is attached to your hemoglobin for 120 days. So remember, this sugar is in your blood, all right? And your red blood cell, especially, it has hemoglobin, which is the carrier of your oxygen. As your blood flows through, it has glucose. So by doing the A1C test, we can see how much sugar has been in your blood. Right? It gives us a good perspective. So if your A1C is great, is 6.5 or above, yeah, you might have diabetes. All right. And this doesn't just help us to diagnose the patient at one time. This is the best way to actually continue to monitor a patient to make sure is the treatment regimen that we have for them is it successful, is it good, are they doing what you're supposed to do? If not, we might have to change their treatment. All right. So you might be asking, why 120 days? The reason for that is because your red blood cell, which carries your hemoglobin, has a lifespan of 120 days. Yeah. So every 120 days, you make a new red blood cell. So that's why we are able to get that good measure of your glucose level versus just doing a random blood sugar test. Now, aside from the A1C, other tests that we can do is the fasting plasma glucose. So pretty much the word fasting already should make you know that this patient is going to be fasting. Yeah. Patient needs to be NPO for at least 8 hours before this test, and then we are going to check their blood sugar. So if someone has been fasting for 8 hours or more, we wouldn't expect your blood sugar to be through the roof because you haven't eaten anything. But if we check your blood sugar after you've been fasting for a couple of hours and it's 126 or above, then something, yeah, you might have diabetes. All right. Another one is the 2 hour plasma glucose level. So 2 hours, pretty much, we're gonna make you drink a 75 gram of solution that has glucose in it. So it has 75 gram of glucose in it. You'll drink it. This is also done for like pregnant women to check if they have gestational diabetes. So after 2 hours of drinking that solution, we're going to check your blood sugar. If it's 200 milligram per dl or above, yeah, that might show that your insulin is not working as it should to regulate your blood sugar level. And then finally, we have the random plasma glucose test. The word there, random, means that we're not going to fast. We're not going to wait 2 hours or nothing. You're just going to come in and we're going to check your blood sugar. If it's 200 or above, that's also a sign that, yeah, you might have diabetes, especially if you also have the three P's like polyphagia, polydipsia, polyuria, or any other symptoms of diabetes. And we randomly check your blood sugar and it's greater than 200 or 200, that might also be a sign that this patient has diabetes. All right. So we've talked so much about the disease process. Now let's actually talk about how it is treated. So how do we manage the disease process?